Welcome to Voices in Value-Based Care. I'm Matt Fusan. Thanks for tuning in. The movement to value-based care is revolutionizing how healthcare providers get reimbursed for delivery of care. On this program, we explore stories from the field about how real organizations are dealing with this change. You can follow the show on Twitter at hashtag VoicesInVBC and follow SPH on Twitter at SPH Analytics. On the program today, I'm speaking with Zen Menon, CEO at Jacksonville Children's Multispecialty Clinic and Atlantic Medical Management, a managed services organization. Welcome to the show. It's great to have you.
Thanks, Matt. I'm looking forward to this conversation.
Before we get into my grilling of you with all my great questions, why don't you tell us a little bit about yourself?
Sure. My previous life, I was a research and development engineer, basically building products for consumer goods. So I used to build microchips back in the day. Around 2009, my dad was diagnosed with Alzheimer's, and I wanted to kind of create something in his honor. So I basically started my first healthcare IT startup that focused on remote monitoring of Alzheimer and dementia care patients. Then over the course of the next 10 years, I worked at multiple startups before 2017, where I got picked up by a private equity group called Broadtree Partners. So I joined them, moved from Berkeley to Charlotte, and now my current home in Jacksonville, North Carolina, home of Camp Lejeune and the Marines who service.
I forgot that was the home of Camp Lejeune. My uncle was in the Marines, and I used to go down for summers, and he was a drill instructor. He'd let us run around on the course on the beach. I have very vivid memories of that now. Interesting. So tell us about your role as CEO and kind of how you got there. It's obviously your background a little bit tells us it was a bit of a unique path there. Just tell us a little bit more about that.
Sure. One of the key things that I was looking for as I joined Broadtree Partners was diving into the whole healthcare space and specifically physician groups, because I saw a need for a lot of physician groups, especially like small to mid-sized practices that needed help on the non-clinical side. And what that means is that when it comes to finance, technology, revenue cycle management, all these different facets, HR, all different facets that, a lot of groups did not work in. They were focused on being good doctors and providing healthcare. So that was kind of my thesis when I kind of came in. And like most other PE groups, we started, with the same, let's focus on urgent care, let's focus on ophthalmology, dermatology, all the, like the prized groups within private equity. So when we started looking at models, we noticed in urgent care that it was more like a band-aid rather than solving a real problem. It was because regular family care docs were time constrained and resource constrained, and they couldn't do much with all these requirements. So they had to kind of end their day early because they had to spend the rest of the day doing their charts. So we said, listen, there's got to be a way here that somebody's doing this differently and in a value-based care model. And we started exploring, and we looked at over 50 practices across the Southeast until we landed on JCMC. And the key thing for us for JCMC was important was that they had basically found a way to kind of embrace the value-based care world being in a rural market, which is a really tough combination. And we said, okay, we can get that model right. We can add the technology and the capital back in to expand that model that would make a difference. That was kind of initial foray into JCMC. And after like a year and a half of diligence, I ended up joining this role.
That's really interesting, especially the perspective of the deep dive into 50 plus practices in the Southeast to really get a perspective that's the unique view that a lot of people and organizations don't have the opportunity to get. Mm-hmm. Based on that and what you're seeing at JCMC, what do you think the unique challenges are from moving from fee to service of value-based care, kind of with your unique background and how you guys assess the space?
Right. So if you take a look at any small to mid-sized practices in a fee-for-service model, they're basically trying to survive because every year there are more regulations and more compliance needs. So you got to find ways of making money. So, and the way small, medium-sized practices make money is that, okay, I can add more tests, more labs, more X-rays, more any kind of ancillary services I can add to kind of, move that, I increase that top line. The issue there is that that's great, but in the long term, that's really not serving your community or the healthcare issues we're facing right now, right? So because the group is trying to survive, the practice is trying to survive, but long term, it's not truly providing value to the community. So I think one of the key things that we see is that if you want to move from fee for service to a value-based care model, is that you have to find a way to keep costs low versus the opposite of keeping costs high by adding all these things. And usually most practices are going, listen, I need to make my revenue to survive. I don't care about the cost. That's actually passed on to somebody else. The issue is that somebody else has to take that burden of that cost, right? And that's where we said we have to find a practice that focuses on making money, but keep costs under check. And that's why we kind of saw the model that JCMC was building really important. So for any practice to kind of switch from a fee-for-service model to a value-based care model, it comes down to the docs and the practice to have that key vision or the core value, so to speak. If that core value is not there, then it's really difficult for you to change that mentality. And I think so it begins from a visionary leader or a physician leader would be the ideal candidate. And from there, building that out across the practice. And that's the only way you can convert that, where not only are you providing value, but also keeping costs low and keeping a practice revenue positive as well.
In some of our previous discussions, we've got to know each other a little bit. And some of those discussions we were talking about, how it's a bit of a challenge because a lot of clinicians have been trained in a very specific way to be individuals, right? And they're the owner of that patient's health, and trying to move clinicians into a path where it's more of a care plan that is followed across the board and standards, as opposed to I'm going to make individual decisions over and over. It's a bit of a challenge. Could you tell us a little bit more about that and how you guys are working on that?
Sure. So this was a conversation I had with a lot of doctors about, how do you view the whole healthcare landscape? And they were like, Zen, listen, the way we were taught was that we are probably the most key individual in this, and there's nobody going to work along with us to kind of solve a problem for the patient. Because at the end of the day, if something goes wrong with the patient, we're to blame. Nobody else is going to take that. So this whole community-based approach or collaborative approach you're talking about, where we have to kind of mix with the different groups, is not in our training DNA. So we have to kind of evolve that thinking, and that with everything, when you've done something for 20, 30 years, that takes time. So we're moving that direction. We want the best for the patient, but we never thought we also have to work on our community as well and costs as well. So that shift is going to take some time for us to figure out, but we want what's best for everybody. So what some of the doctors have done is that some of the JCMC docs have gone around, had these conversations, and talked to the different clinicians and said, listen, we can achieve both if we just focus on trying to make an impact by having as many patients as possible, at the same time keep the patient satisfaction also high. We got to find that balance. Once we find that balance, I think we'll be able to create a greater impact, because as each clinician goal is like, I want to make a big difference in my community where the healthcare needs are not as significant versus other needs. And that's their goal. So that's what they're trying to work on, right?
And I want to step back a little bit, and again, I have a question, a broader question, and especially again with your perspective and the analysis that you all did moving into this space. Do you think the healthcare, and a bit of a loaded question here, do you think the healthcare industry has figured out the business model for value-based care? And do you think the business model looks differently depending on type of organization, right, or where the care is being delivered? Often value-based care is just such a huge term and encompassing everything, but within healthcare, there are clearly very, very different ways to deliver care and points in the care continuum. So what are your thoughts, big picture, business model wise? Have we figured out, is it going to look different across care settings?
Right. So if you think about the value-based care model, right, it's nothing new. I mean, like we've had this thing around for like
Right.
20, 30 years, right? So they did that back in the day, the HMOs, and they tried that, I mean, like for a while, and it wasn't as successful. But I think it's different this time, and it comes down to dollars and cents end of the day, right? So you have a total healthcare expenditure that's rising on an exponential basis. You almost have your total healthcare expenditures offsetting. I mean, even going beyond what you have with the growth of the U.S. economy, and CMS expects that to grow. So when you have a situation like that, when there's no other options, you have to switch to something different. The fee-for-service model is not going to be able to sustain itself if these costs keep growing, because somebody has to, I mean, like take the burden. And I think
Right.
now it's a time where they have to kind of find an answer to this. I mean, you can, keep kicking the ball or kicking the can down the road, but how long can you do this without the whole thing imploding? So I think there's going to be a shift that's happening. And I think that, the government will recognize that sooner and make value-based care, the choice versus the fee-for-service model.
And when you were looking, did you see differences between, the ability to effectively manage and successfully manage value-based care at an ambulatory practice level as opposed to an acute level? There's some clear fundamental differences there. I'd love to hear your thoughts on that.
I think when it comes to like a family care model, it's based on relationships, right? So if you can hold on to relationship long term, you can cut those costs down. If you're doing an episodic situation like ambulatory, it's going to be a little bit more challenging to do so, because you're not going to have a patient listen to you long term. How do I cut the costs down? But then the way you can balance it is your family care doc telling you not to go to the ER every chance they get, but instead, hey, why don't you come in and we can give you like a quick prescription or a pill that will solve it temporarily, and it'll usually go away. So I'm not saying that's the thing you apply across the board, but a majority of cases you can solve those needs and solve those costs by balancing. So it has to be a partnership between the between the ambulatory side and the acute side, right? I mean, like, so one has to kind of help the other one and recognize what the needs are, when they need to be sent out and when it has to be in-house. So I think once you strike that balance, you'll be able to be more effective value-based care on both sides of it.
And developing those relationships is such a core part of it. The pop-up clinics and everything else, the CVS, and kind of go in the opposite direction, right? Just, hey, go get the point and care, no history, none of those things, which work great for flu shots and other things, but especially in a population that's getting older, that would not be the best path for really controlling costs, right? You got to really work with your family clinician. And the family clinicians tend to be more, and you mentioned this earlier, tend to be more aligned with community and community services, right? And all the other things that come into play for care, as opposed to just the doctor's appointments themselves.
Mm-hmm.
In some of our previous discussions, I know we talked and you kind of view it, the healthcare community, let's call it, kind of into 4 different groups of stakeholders. Can you tell us what those 4 groups are and kind of see how you see them interacting, working together, and kind of from our conversation really being key to success is collaboration amongst those groups?
Right. So the way we've kind of done it with JCMC is we looked at along those like 4 groups, so to speak, right? The first group is our patients. So our goal is to kind of serve our patients. The next one, we need to support our providers. Third is empower our own people. And the last one is value our payers. Now, most practices will go value our payers. I mean, that is pretty much what blasphemy or where I've heard people say, the payers are devil and all that stuff. But the way I kind of recognize is that at the end of the day, if you're not a concierge practice, you have 2 customers. You have your patients and you have your payers. You have to understand where both their value proposition is and what they're trying to get from it. Because in a way, we're trying to kind of serve each other's need. So kind of building that relationship with the payers, so their costs don't constantly keep going up, and they have to keep paying out. We can find a balance between them. They're going to try to find ways to kind of help us grow the practice as well. So that's the collaborative piece that we want to build on with our payers, and we did that quite a bit during our Medicare transformation, where we had to work with 5 primary health plans, and they all understood what we're trying to do, and they were willing to reward us for that. So there is value in that particular collaboration, with that group as well. The other 3 groups, I'm sure, like with patients, provider, and our people, that's fundamental to any practice.
Yeah, I think that unique fourth one is exactly the interesting one, right? The payer side and the statement you made, practices, have 2 customers, patients and payers, is definitely a unique view. I can say I've never heard those words come out of somebody's mouth like that. So that is definitely a unique view, but it's healthy, right? We got to move past this us versus them mentality, because it hasn't gotten us to where we want to be right over the past 3-4 decades. So that's not going to change. So I think that mindset changing to, we're not enemies sitting down and fighting across the table every couple of years over rates, but we're truly partners to deliver, care to the people that we're supposedly our ultimate customers, right? Our patients.
Mm-hmm.
So I love that perspective. And I think that is the reality of when we do get further down the path and we see a lot more true value-based care, it's going to be that collaboration between payers, practices, and the other 2 groups all working together, as opposed to the kind of us versus them scenario that we live in today.
Mm-hmm.
So for JCMC, what specifically are you guys working on to transform the value-based care? What approach are you taking? Have you already started doing some things? Are you planning to continue? And I know there's some activity in the state level, Medicaid, where they're trying to move into more value-based care type of things. And there's a little hiccup here and there, I know, recently, but kind of interested in what you're all doing today in your transformation of value-based care.
Sure. I like, one of the things I like to take a step back is to kind of say how this whole journey started. And one of our physician leaders, Dr. Mittal, he kind of saw this around 8 years ago. He said, listen, the way to kind of survive and thrive in the future is to focus on value-based care, and that should be our vision. And and we need to build this vision. So the easiest answer for that is that, well, we need to do a PCMH, or a patient-centered medical home. That was a thing that everybody's doing towards value-based care. But what we saw as a PE practice, a lot of groups who are doing PCMH was this box checking. Okay, let's get this done. Let's get this done. And that was an easy way of doing it. Okay, now we're PCMH. But I think what Dr. Mittal did really well was that he was able to kind of say, let's integrate that PCMH way of thinking into our practice, right? And so that was one of the key things that he told all his clinicians, how we are going to be different from the other groups. On top of that, one of the things they did really well was that, okay, let's embrace technology. And that's like a very cliche statement, but what he did was that he took his EHR. So we use NextGen, and we customized the EHR to a very fine degree, where doctors were not taking time doing their charts and reducing that time shorter and shorter. And that was key for him, because that's what he worked on, because he knew to actually make it successful, you have to see a lot of patients, but at the same time, focus on, patient satisfaction. And for that, he integrated with a company called Connect and brought in patient satisfaction surveys constant. So every time a patient comes in, once we check in, when they're leaving, they get this survey they have to finish. So that was a balance he was trying to find between volume and when it comes to satisfaction. Then after that, it started going down the technology integration. How do we start building interfaces across different groups? So we have things here called the NCHIE and the CCHIE. HIE basically means Health Information Exchange. So he started connecting the next-gen thing tool with different interfaces. Then he started integrating with labs and patient portal. So everything that can bring value into the system he was creating. So that was the first piece of all this, right? Embracing the technology piece. The other part of value-based care is you got to reduce costs. Well, how are you going to reduce costs? And that comes to educating your providers. So he took time in actually going to each of the providers and telling them, hey, there's value-based care. We got to do the things differently. We got to manage our patients differently. So he started doing that. They had an option to add x-rays and labs and all that stuff. They said, no, we're not doing any of that. So he basically tracked the measures, and the organization tracked to see how many x-rays are really required. So when they moved x-rays outside, they realized there was never a need to do x-rays most of the time. X-rays basically ended up being a crutch for the doctors to kind of say, oh, I'm going to have a backup. Long term, what that built was you end up getting better clinicians who have the experience of the years and their gut to make decisions. That's what they went to practice for. So that art kind of resurfaced itself without using the other ways of making money. And then other things about looking at drugs and stuff like that. So they would use a lot of generic drugs as a default, rather than picking the most expensive drugs. So almost to a point, a lot of pharmacy groups weren't visiting the practice anymore because we weren't doling out the expensive drugs. So that changed. Again, a cost factor, right? So all these small things that people don't think about, these guys were focusing over the years, and all the doctors said, okay, this is the way we're going to practice medicine when it comes to JCMC, and how we're going to make impact to this the group we're working with, all the different communities, the payers, and our people. This is how we make a difference, by focusing on technology and reducing costs.
And how's the actual rollout going? I know we had some discussion, and I think you kind of got like a hub and spoke approach, right? You kind of got the central location where you make things happen, and then you roll those out. Because I think one of the challenges a lot of organizations have is, okay, if we have a couple people focused on this, we can get all the data, but then it's the execution of changing the culture across the whole space. What are you guys doing there?
So that's probably been one of our initial challenges, because we have like a campus setting and our satellite clinics. So what we used to do was we used to bring our providers in for weekly and monthly meetings to kind of educate them. But over the years, we realized we have to be in those clinics and kind of talk about these things on a regular basis. So what we're doing is that each of us are spending time in various satellite clinics to kind of engage with the different entities. When it comes to our patient service representatives at the front desk, or our nurses, or medical assistants, or our doctors. The fact that we realize when we're more engaged, people are more open to kind of accepting our vision. It's easy to kind of have a vision from the top down, but we're now in the process of building that from the bottom up as well, or should I say from the clinic to the central thing. So we've tweaked our model a little bit to kind of that, and we're having very good results. We're seeing better kind of when it comes to the value-based care numbers we track, we're seeing those boxes check more than they were before.
And that's interesting, getting out the difference between having people come in for training, right, even if it's pretty regularly, versus you all getting out to the work setting and the practice setting and interacting with people, and how big a difference that makes. I think that's a great lesson learned for everybody, that little tweak. And like you said, getting out into their environment and seeing how they're doing things gets a lot more buy-in than, all right, everybody come into the corporate office for the day, we're going to do some training, and then everybody just disperses. That's a great model. So I have one last question for you here, and it's kind of wide open. And it's kind of, what do you think the next 2 or 3 years are going to look like for JCMC?
I think, the Medicaid transformation being suspended was definitely, something that held us back for a little bit, maybe over a couple of days, but we decided that that's not going to stop us what we're doing. So one of the key things that we're already working on and will continue to work on is this consortium between ACPH Analytics, SmartLink, and us. So where we're integrating population health, EHR, interoperability, and our clinical side to kind of work together. And our side will involve the care management function, care coordination, all that. So we're planning to move forward in that, because we know that's the best way to practice medicine, and that's how you're going to deliver healthcare to the community. we need technology to make a difference, and partnering with groups like SPH and SmartLink, who have kind of done this for years and tested out, is the only way we can grow and make this whole value-based care concept not just an idea or, I mean, like something nice to have, but a reality and a part of a daily clinical workflow. We're hoping a lot of practices will join us in this journey. We're already talking to like a couple of pretty large groups, and in time, that partnership will make value-based care a reality, not just in eastern part of North Carolina, but across North Carolina and beyond.
Excellent, and I think great that you're continuing forward, because there's so many fits and starts at the government level, right? Like you said, with the Medicaid program, it was going to be a go, now it's a delay, and to just make the decision of this is the way we need to operate, right? This is the way we need to practice medicine, be financially viable, and continue to provide great care to the population within our area. And generally, what we've seen is those are the organizations that end up being successful in the long run, right? It's not we're only doing it because of deadlines, and as soon as that's off, we're just going to go back to our old ways. So congratulate you on that, and look forward to seeing how everything turns out here in the future. And of course, we'd like to invite you back at some point in the future and get an update. So hopefully you'd be open to that.
Absolutely, Matt. I appreciate the conversation, and especially the focus on value-based care. I don't think a lot of groups are thinking about this, because everybody is looking, well, value-based care is not a reality yet, so why bother talking about it? But I'm happy to hear, there are groups out there like yourself, who are going the extra mile and say, we think this is a reality as well. So, and we want to, talk about success stories and what's happening. So I appreciate your guys' dedication and investment of time and energy towards this. So thank you for your time.
Absolutely. Thank you. And thanks to our audience for tuning in. You can learn more about the show on the programs page on healthcarenowradio.com. That is healthcarenowradio.com. And lend your voice to a conversation on Twitter, again at #VoicesInVBC, and be sure to follow SPH on Twitter at SPH Analytics. I'm Matt Fusan, bringing you voices in value-based care you should hear. Until next time, have a great week.